Okay, Assalamualaikum and good afternoon. So today we are very grateful to have Saifuddin to talk to us regarding motor sparing blocks of the wrist and ankle. Now to be fair, we as anesthetists, we're probably not gonna do much of wrist and ankle blocks, but there is still some benefits to knowing the techniques, even though they are not generally applicable. Okay, so I think without further ado, Saifuddin.
Okay, Assalamualaikum dan selamat petang. Today I will talk about motor sparing block of the wrist and ankle. So first we go into wrist block. So what is actually a wrist block? It's a distal peripheral nerve block designed to provide anesthesia to the hand and finger by targeting the median, ulnar and also radial nerve at the wrist level. It avoids the upper arm motor blocks and allow hand surgery under mild sedation and ideal for procedure like carpal tunnel release and even in arm-busted patient. Therefore, that is why this is called one of the motor sparing block because the patient still can move his hand. However, there's a limited movement at the wrist due to block of the hand muscles. So what are the indication and also contraindication of the wrist block? Usually, wrist block can be used for any surgery on the hand or fingers. Examples such as carpal tunnel release and also tendon repairs. And contraindication includes local infection at the injection site or allergy to the anesthetic agents. Or also wrist block have a limited tourniquet tolerance lah. If upper arm tourniquet tolerable around 20 minutes and also wrist around 120 minutes. So next week, we learn a bit about the innervations of the nerve. So first is the median nerve. So median nerve actually travels through the carpal tunnel. It lies between the palmaris longus and also the flexor carpi radialis tendon at the wrist. It supplies the sensory innervation to the lateral palm and also finger, the first 3.5 fingers, that is the palmar side. It also provides motor to the tena muscle and also first and second lumbrical, that is the intrinsic hand muscle. So as you can see in the picture, the lower picture shows the innervation of the median nerve. So next we go into the ulnar nerve. So ulnar nerve actually run along the ulnar artery under the flexor carpi ulnaris. It supplies the sensory to the medial one half of the finger, both palmar and also the dorsal aspect of the hand. It also provides some motor supply to the most intrinsic hand muscle, such as interossei, hypothenar, abductor pollicis, and also third and fourth lumbricals. So next we go into the radial nerve. So radial nerve crosses the anatomical snuff box and becomes subcutaneous near the radial styloid. It is purely sensory at the wrist level and supply the dorsal aspect of the thumb, index and also lateral half of the hand. There is no motor function at the wrist level for radial nerve. So this picture show the anatomical landmark of the nerve of all the three nerves, that is the median nerve, ulnar nerve, and also the radial nerve. So the patient to do this block, we ask the patient to lie down in supine position with the arm abducted and wrist should be kept in a slight dorsiflexion. So first we go into the anatomical landmark block of the radial nerve. So to block the radial nerve, it done as a field block because it is because of its unpredictable path and also branches into many small sensory nerve. So we inject around 5 mL of local anesthetic just above the radial styloid, moving the needle medially. Then we inject another 5 mL of LA laterally to cover the full area of the nerve. So actually the radial nerve also give branches, that is the dorsal sensory branches of the radial nerve. So to block this nerve, we insert the needle 1 cm above the radial styloid on the lateral side of the radial artery. So the nerve runs between the brachyradialis and also the extensor carpi radialis longus, about 5 to 8 cm above the styloid. So we advance the needle towards the listed tubercles, and also we inject 5 mils of local anesthetic under the skin in that area to block this nerve. So one second, this video will show how we do the anatomical landmark of block of the radial artery. Okay, so that video show how we block the radial nerve anatomically. So next we go into the block of the ulnar nerve. So for the blocking of the ulnar nerve, we insert the needle under the flexor carpi ulnaris tendon near its end, and also just above the ulnar styloid. So we advance the needle around 5 to 10 mm and inject 3 to 5 mils of local anesthetic. Also inject 2 to 3 mils of subcutaneously just above the tendon to block the cutaneous branch of the ulnar nerve, which supplies the hypothenar area. Okay, this is the video to show how we block the ulnar nerve. So next is the block of the medial nerve. So for medial nerve, we insert the needle between the palmaris longus and also flexor carpi ulnaris. So we advance it until it touches the bone, and this confirm you have passed to the deep fascia. So then after that, we pull back the needle around 2 to 3 mm and inject 3 to 5 mils of local anesthesia here. Okay. So next we go into the ultrasound guided techniques of the wrist block. So first I'll talk about the ultrasound guided block of the median nerve. So for the median nerve, it travels to the center of the forearm from the brachial artery, and that lying deep under the flexor muscle as seen in the video before. So we put the transducer is positioned in a transverse orientation over the anterior aspect of the mid forearm, at least 5 to 10 cm proximal to the wrist crest. So the median nerve appears as an oval hyperechoic structure. So at the wrist actually is more superficial, however in the wrist is more confusing because the nerve can be confused with the tendons of the FDP, FDS and also FPL. So this picture shows the sonoanatomy of the nerve. As we can see, the label MN is the median nerve between the three muscles of the wrist. In this picture, actually, the ultrasound is placed in the mid wrist, means away from the wrist, so more proximally to prevent confusion between the medial nerve and also all the tendons. In the next in the video, you can see the pictures in the wrist and also in the mid forearm. So this is a similar picture showing sonoanatomy of median nerve. Okay, so next we go to the ultrasound guided block of the ulnar nerve. So for the ulnar nerve, it actually runs on the medial side of the ulnar artery from the mid forearm to the wrist, making the artery is one of the useful landmark to identify the ulnar nerve. So we place the transducer in a transverse orientation over the anteromedial aspect of the ulnar side of the forearm. The ulnar nerve can be seen as a triangular or oval hyperechoic structure that is medial to the ulnar artery. As you can see in the picture, this is the ulnar artery and the ulnar nerve is located lateral to the ulnar artery. So we scan proximally, useful to distinguish between the nerve and also tendon of flexor carpi ulnaris. So the best point of injection is actually when the artery and also nerve starts separating. So this is the picture of the sonoanatomy of the ulnar nerve. As we can see, we put the probes as transverse orientation, and we can see the ulnar nerve beside the ulnar artery at the level of mid forearm. Similar picture showing sonoanatomy of the ulnar nerve. As we can see, the probe is placed transverse, and we can see the ulnar nerve is beside the ulnar artery. Next, we'll see the video showing the ultrasound block of the ulnar nerve. So next we go to the ultrasound guided block of the radial nerve. So at the wrist, the superficial radial nerve actually splits into small branches, making ultrasound guidance less useful for blocking it. So instead, a subcutaneous field block near the radiostyloid is simple and effective. The nerve is better visualized at the mid forearm, So usually for to block the nerve at the mid forearm, we place the transducer transversely at the anterolateral aspect of the mid forearm to identify the pulsation of the radial artery. And is the radial nerve is imaged as a hyperechoic structure lateral to the artery and superficial to the radius bone. So this picture shows the sonoanatomy of the radial nerve. As we can see in the mid forearm, the radial nerve can be located by locating the radial artery, and it is at the proximity with the radial artery. This is a picture similar showing the radial nerve that is beside the radial artery. So next we go into ankle block. So for ankle block, what is ankle block? Is an ankle block that provide anesthesia to the foot by blocking the 5 peripheral nerve at the ankle. It is based on easy identifiable landmark and doesn't need to use a special tools, nerve stimulator or patient cooperation. And also it is reliably safe and also effective for any foot surgery. Although it can impair walking, it affects mobility less than sciatic and popliteal blocks, and patient can usually go home before it wear off. Using long-acting local anesthetic give excellent pain relief after surgery. So actually the foot is innervated by 5 nerves. So the nerve, the first one is the saphenous nerve. It's a terminal branch of the femoral nerve and innervate the middle aspect of the leg below the knee. As you can see in the picture, is depicted by the pink color. The rest of the foot is innervated by the branches of the sciatic nerve. That is, first is the sural nerve. Sural nerve innervate the lateral margin of the foot and also the ankle, can be seen as a green color, and also the superficial peroneal nerve that innervate the dorsum of the foot. Then also we have the posterior tibial artery. Posterior tibial artery provide the innervation. Posterior tibial nerve that provide innervation to the intrinsic muscle, bones, and also joints and skin of the heel and sole of the foot. And we also have the last one is the deep peroneal nerve that innervates the extensor digitorum brevis and also extensor hallucis brevis muscle and all the deep structure on the dorsum of the foot. It's terminate as a cutaneous nerve and supply the skin between the hallux and also the second toe, as you can see in this picture. So this one like a cut section of the foot. As we can see, there's a saphenous nerve, the superficial peroneal nerve, the posterior tibial nerve, and also the this one saphenous nerve. Saphenous nerve, deep peroneal nerve, superficial peroneal nerve, and sural nerve. Sural nerve is this one. So for anatomical landmark, actually for all the 3 nerves, that is the saphenous nerve, superficial peroneal, and also sural nerve, can be blocked superficially because it located at the level of malleoli. So all these three nerves can be blocked by giving a ring block around the level of malleolus. So the saphenous, superficial peroneal, and sural nerve are subcutaneous. So we can block by giving a ring block. So from anterior to the Achilles tendon, medially to the lateral side of the foot. So this picture show how we give the block of the superficial peroneal nerve and also the block of the sural nerve. So next we go into the deep peroneal. So we have two deep nerve that should be blocked at the level of the for ankle block. That is the deep peroneal nerve block and also the posterior tibial nerve. So for deep peroneal nerve block, we identify the extensor hallucis tendon by asking the patient to extend their big toe. So when they extend their big toe, we can identify the extensor hallucis longus, and then we insert the needle lateral to the tendon and perpendicular to the tibia, and is advanced until in contact to the bone. So when it's in contact, we withdraw the needle for a few centimeters, and then after negative aspiration, we inject 5 mils of local anesthetic. So this picture show how we give the deep peroneal nerve, where we inject in the lateral to the hallucis longus, extensor hallucis longus. So for posterior tibial nerve block, we inject its posteriorly to the path of the posterior tibial artery behind the medial malleolus. So first we palpate and then we inject the local anesthetic posterior to it. However, if the artery cannot be palpated, injection can be done between the Achilles tendon and also the posterior aspect of the medial malleolus. So the needle can be directed toward the tibia at a 45-degree angle to contact the bone, and then we withdraw a few centimeter and after negative millimeter and then we can after negative aspiration 5 mils of local anesthetic is injected. So lastly we go into ultrasound guided of the ankle block. So first I'll talk about posterior tibial nerve block. So transducer is placed in the transverse orientation between the medial malleolus and also the Achilles tendon. The tibial nerve lies, like I said before, posterior to the posterior tibial artery. So to locate this, we can use the help of color Doppler, and it appears as a oval hyperechoic structure, and the nerve can be tracked proximally to differentiate it from tendon as the tendon transition into muscle as we shift the transducer proximally. So this picture shows the sonoanatomy of the tibial nerve block. As you can see in this picture, it's actually located near the posterior tibial artery. This also shows the picture of the orientation of the tendons and also the artery and also the nerve in the ankle. So we can see this is the medial malleolus, and also the posterior tibial nerve is located actually posteriorly to the posterior tibial artery. So as we can see, as we shift the probe proximally, all the tendons has already shift into the muscle, and we can see only the nerve with the artery, and we can locate the nerve more easily. So next, for the deep peroneal nerve, so the transducer is placed in the transverse orientation on the anterior aspect of the ankle, and is seen as a two small hypoechoic fascicles with hyperechoic rim immediately lateral or superficial to the anterior tibial artery. So in this picture, we can see that the nerve actually present at the side of the anterior tibial artery. This is the deep peroneal. Therefore, because in the anatomical landmark, usually we give to the after we give injection, we give the injection sometime to the right and also to the left of the to right and also to the left, means to the lateral and also medial, to spread the local anesthetic. Okay, so next we go into superficial peroneal nerve. So for superficial peroneal nerve, actually it's emerged at 10 to 20 centimeter proximal to the lateral malleolus to lie superficial to the crural fascia, and is located between the lateral and also anterior muscular compartment. So we place the transducer in the transverse orientation 10 to 15 centimeter proximal to the lateral malleolus. So we can see the peroneal nerve as a hypoechoic flat surface at the intersection between the crural fascia and also the intermuscular septum, as separating the lateral and anterior muscular compartment. So as you can see in this picture, we can see the superficial peroneal nerve between the crura and the compartment, between the muscle. This one. Okay, so next we go into the sural nerve. So for sural nerve, it runs in the superficially along the posterior midline of the leg. The transducer can be placed in the transverse orientation between the posterior border of the lateral malleolus and also the Achilles tendon. So it appears as a tiny hyperechoic oval structure in a close contact with the lesser saphenous nerve. So in the next picture, we can see we place the probe in the transverse orientation, and this is the This is the small saphenous nerve, and also we can see the sural nerve in proximity with it. In the sono anatomy, we can see also the similar picture showing the sural nerve beside the small saphenous nerve. Small saphenous vein. So this video show how we block the sural. So next is the saphenous nerve. So to block the saphenous nerve, it actually travels down the middle aspect of the leg alongside the great saphenous vein. So it is best seen on the ultrasound about 10 to 15 centimeter above the middle malleoli using the vein as a guide. So we can also use a cuff tourniquet to help enlarge the vein and also improve its visibility to easily locate the saphenous nerve. So in this picture, we can see that is the saphenous nerve in proximity with the saphenous vein. Okay, and that's all. This is my resources where I take the resources in Misora and also YouTube of regional anesthesiology and acute pain medicine. Thank you.
Okay, thank you, Saifuddin. Can you just go back? Ultrasound guided wrist block. So, in my personal experience, I prefer doing it because I can do it's very simple, and so we know that the more distal we do our blocks, the lesser the risk of nerve injury. So basically, when we do regional anesthesia, we want to balance the ease of the technique, the number of rejections, etc., versus the risk of complications. I find that if I just want to do something on the hand for a brief procedure, I can get by with just doing a wrist block. But the main problem with doing a wrist block with the landmark technique is that you have to account for the branching of those terminal nerves. And the ulnar, the median, the radial, they all start to branch at the wrist level. So that's why you see that there's quite a bit of fanning here and there that you have to do to account for all the branches. However, if I do an ultrasound guided approach, just at the mid forearm, I can easily block all three with just 3 injections without the need for fanning. So all you have to do is at the mid forearm, identify the FDP, FDS, and then you'll be able to identify the median nerve, and then go to the next one. So you can go to the ulnar. Okay, so then you just go to the ulnar, you just look for the ulnar artery and you can find the ulnar nerve over there. And then, so then you can just go to the, so you just go to the ulnar artery, you can find it just beside the, ulnar nerve will be right beside the artery, and then you can just go to the radial nerve. And all you have to do is follow the radial artery, and once you go proximal, you will be able to find the radial nerve going below the brachioradialis and superficial to the radius bone. So by scanning proximal and distal, you will be able to follow the nerve. So for me, I find that there's quite a bit of utility in doing a wrist block under ultrasound because it is much simpler than doing a landmark approach, and then I can get reliable, much more reliable block with the added benefit that there is very minimal motor block, because the only thing that you are going to block with a wrist block are the intrinsic muscles of the hand, whereas the main flexors, extensors are all those muscular branches are all branched out much more proximal. So they are all unaffected even by doing a mid forearm block. However, for the ankle block, I personally have not done any ankle block under ultrasound because, like I said, if I do a popliteal and sciatic, I think it is still more simple than trying to do an ultrasound guided ankle. So therefore, in this particular instance, I would feel that I would probably, if I really want to do an ankle block, I would probably just do a landmark approach, because the landmark approach is quite easy, because you can block the saphenous, superficial peroneal, as well as the sural just by doing a ring block. And then all you have to do is look for the extensor digitorum slash the anterior tibial artery, and then you can inject the deep peroneal, and then you just look for the great saphenous vein and inject around it to block the saphenous nerve lah. So for me, if I really want to do an ankle, I would rather just do under landmark, because it is just as simple as doing under ultrasound, which is much more complicated. The only good thing about ultrasound is that you will probably be able to really identify the tibial nerve reliably, which has been, in my experience, the main problem in getting consistency. So if you can see an ultrasound, you can easily block it very well. The other thing is the deep peroneal nerve. If you want to do it under ultrasound, one of the easiest way is to just scan proximal and distal, because you would see it rolling over the anterior tibial artery. So that's the clue. It crosses over from one side to the next as it goes from proximal to distal. Whereas the other parts of the nerve, maybe there's utility, maybe there is not. Of course, if you want to do it, I mean, just doing a ring block for superficial peroneal is quite easy enough. But if you really want to do it under ultrasound, you can identify it by looking for the fibula. Even in this picture, you can tell on the dissection as well as the ultrasound image that the fibula tends to point towards where the superficial peroneal nerve would be. Okay, so we have some questions here. Hi, from your experience, what is the best strategy to prevent movement intraoperatively? I think whether it's deep sedation, light sedation, or wide awake, I think this is all individualized. Because, for example, if you have a trauma of the finger, and all the patient needs is just a simple K-wire, young patient, very cooperative, then I don't see the harm in doing it wide awake. Despite what is described here regarding tourniquet tolerance, so far for short procedures, just inserting a K-wire, even though it's longer than 20 minutes, I found that patients can generally tolerate upper limb tourniquets quite well for such short procedures. Of course, if you are doing an infection case in a patient that's a bit septic, then maybe some sedation would be required, but these are all individualized approaches. And I wouldn't say that any one size fits all. I think for wrist block, I would, if I have the utility of ultrasound, I would probably do ultrasound guided wrist. But for ankles, if I really need to consider doing something, I will probably just do a popliteal plus adductor. I think that's much faster for me. Okay, I think if there are no further questions, then I think we shall thank Saifuddin in the usual manner lah. Alright, thank you.